My name is Clara, and I am the public education event coordinator at NAMI-NYC, who is the host of this event. This is Trauma, Healing, and Psychedelics, Clinical and Research Perspectives, an educational panel discussion hosted by NAMI-NYC. The event is going to be live streamed to Facebook. I don't believe that has started as of yet. And it is also being recorded. So we will be sharing the link to the recording after the event. We will be starting our Facebook live stream in just a moment. Okay. There we go. We are gonna just go right in. Again, the host of this event is NAMI-NYC, the National Alliance on Mental Illness of New York City. I'm gonna just say quick, oh, here we go. There's our live stream. Hello to everyone joining us from Facebook. As I was saying, NAMI-NYC, the National Alliance on Mental Illness of New York City, is the host of today's event. Our mission is to provide support, education, and advocacy to individuals and families impacted by mental illness. This means that we have free virtual classes and support groups for people living with mental health issues and for anybody supporting someone who is living with a mental health issue. All of our services are free of charge. And all of our classes and groups are facilitated by volunteers who are themselves either living with a mental health issue or supporting someone who is. So that's what we mean when we say peer-led. I could say more, but we're going straight through since we were a little delayed to begin. So if you would like to know more, please go to our website at naminyc.org or call our helpline. And I'm going to, we're going to put that phone number in the chat as well. But for anybody calling in, that is 212-684-3264. Okay, for this conversation, we are really honored to be hosting Dr. Gita Vaid and Dr. Rachel Yehuda. Dr. Vaid is a board-certified psychiatrist and psychoanalyst practicing ketamine-assisted psychotherapy in New York City. She is a co-founder of the Center for Natural Intelligence, a multidisciplinary laboratory dedicated to psychedelic psychotherapy, innovation, and clinical practice. Dr. Vaid is also a MAPS-trained psychedelic psychotherapist and is on faculty and a lead instructor at the Ketamine Training Center. Dr. Rachel Yehuda is an endowed professor of psychiatry and neuroscience of trauma. She is also director of mental health at the James J. Peters Veterans Affairs Medical Center. And last year, Dr. Yehuda established and now directs the Center for Psychedelic Psychotherapy and Trauma Research and has been named one of the most influential women in the psychedelic field. So we are really grateful to be hosting both of them for this conversation. I want to start off by just establishing a little bit of background for folks. This event is sort of talking specifically about trauma and psychedelics and trauma treatment. So I would love it if you both could speak a little bit about trauma more generally. How does trauma affect the brain? And what does healing from trauma look like? What does it look like more generally? And then we can talk a little bit about how psychedelics can contribute to that more specifically. And Dr. I don't know, Dr. Yehuda, if you could start off, that would be wonderful.
Sure, thank you very much. I'm so thrilled to be here. So how does trauma affect the brain? Well, there isn't just one way that trauma affects the brain. A lot of it has to do with when you're traumatized and how many times you're traumatized and what kinds of trauma you experience. What what traumatic events really do is disrupt our neural circuitry and change the way we think. I think that's the most important thing to take out of it, that trauma really does disrupt our patterns of cognition and how we think about the world. The way that this works from a biologic perspective is that you have a traumatic experience, let's say a fight or flight response, which results in the release of stress hormones like adrenaline and cortisol, and maybe due to a prior risk factor, you have too much adrenaline going on, which causes your traumatic memories to form differently, to be more linked with the fight or flight response. And that activates a part of your brain called the amygdala very, very often. And so this circuit that really dampens down the amygdala, the prefrontal cortex, starts having to work really hard. And pretty soon, after a while, all of the changes that result from constantly thinking about the event and being triggered by the event result in general inflammation, including in the brain, epigenetic changes, changes in circuitry, and pretty soon you're kind of wired to go towards a smooth path of thinking about the trauma, but not so much building new kinds of associations and memory. So really it's the way people think that is what causes some of the problems in PTSD. And I'll let Dr. Vaid maybe talk about what healing might look like.
Thank you, Rachel, and thank you for inviting me. It's a pleasure to be here in conversation with everyone. So trauma for me as a clinician, people come to my office complaining of really mental suffering and being in distress. And oftentimes there might be clear triggers that they can identify that contribute to this feeling of suffering or pain, psychic pain. It might be an event or a trigger or a traumatic episode. But usually what we see once you go deeper, there's usually a stacking effect of early vulnerabilities upon which the isolated event or series of events have fallen. And obviously with traumatic events and flashbacks and re-experiencing and ruminations, there's a much higher tendency towards depression and anxiety and panic attacks. And so you typically will have a constellation of all of these different symptoms and expressions that will oftentimes guide people to a mental health practitioner seeking help.
Yeah, that's a great baseline foundation to sort of to go into our next question, which is just why are psychedelics particularly of interest to clinicians and researchers that focus on trauma? Can you talk a little bit about that?
Yeah, I can maybe start. I think why I'm very interested in it is that for a long time we have understood that the way that you heal from trauma and PTSD is through processing the traumatic memory. Sometimes it involves confronting something very, very difficult, kind of talking about it. Most people don't want to confront or talk about their traumatic memories, and the reason is because they're very, very distressing. And a lot of times what goes unspoken, I mean, the fear part, the helplessness part, the horror, that gets talked about a lot. But the part of trauma that is sort of more stigmatized and harder to talk about is the shame that people feel when they're traumatized, the guilt, the self-blame. And so every time the traumatic memory is kind of brought up for discussion, if you've had the kind of trauma that makes you feel like you didn't behave as you should, and many trauma survivors feel that, it's usually what we call a maladaptive cognition. It's usually no basis for it. A lot of assault victims feel that they provoked their perpetrator. A lot of war veterans feel that they needlessly hurt civilians and they shouldn't have done it. And they have a lot of guilt around things like that. Even children, when they're traumatized early in age, they're told by so many people how powerful they are. They're so attractive that this adult can't control themselves. Or if they don't keep silent, the world will detonate. So they get this sense that they're very powerful. And so when there's an act towards them that they don't like, they reason, well, maybe I want this because I'm so powerful. Why didn't I stop it? So a lot of things get very confusing. And so when people start doing these classic trauma-focused therapies, they get distressed and they can't fully engage. And then they drop out or they don't really go there. A lot of times the therapist will see this and treat the patient with antidepressants. It's an attempt to reduce the distress as well as some of the arousal, but sometimes that can make a patient too numb to fully engage in the correct processing. So what happens is you're not in an optimal, we call it window of tolerance. Psychedelics may help people really get into this optimal window of tolerance by making you less afraid to confront your traumatic memory, by increasing your self-compassion so that you can forgive yourself a little, give yourself a break. You're not the monster you think you are. And also it builds interpersonal trust with the therapist. So these are really great qualities of the medicine, but the key in healing is still doing the psychotherapy. So this isn't a magic pill that you take and whoosh, your PTSD goes away, but it is an intervention that can be made so that the trauma work can be done in the correct way.
Absolutely, that makes a lot of sense. So it's really a facilitator rather than something that is having an effect. Obviously, it's having an effect in and of itself, but it is more, in addition, facilitating the relationship, facilitating a state where healing can then occur. Dr. Vaid, would you like to speak about that from the clinical perspective?
An example, perhaps, because Dr. really clarified so beautifully the elements involved and also how much of it is a process of psychotherapy. But I'll give you an example from this morning because it's very fresh. This was a gentleman in his 50s who, when he went into a ketamine experience, started getting tremendously anxious and was surprised that instead of calming down, he started getting very activated, started feeling anxiety in his chest, and remembering a hospitalization where he had been in the hospital for 2 months with a life-threatening infection and how terrifying it was. And even the administration of the ketamine had prompted it. And he got a bit concerned, saying, far from feeling better, I'm feeling more anxious. In fact, the trauma was coming up in a very full way. And he started really panicking and not feeling very good about it, feeling almost like this is coming up and is this helpful or is this re-triggering? But then when we gave him a little bit more medicine, it kind of shifted because I shifted the context of the experience, adding music. We listened to music in these sessions, and it shifted to him actually being able to let go and release and actually find safety in his body, safety in his mind, safety in the experience of the music, and release and feel that the anxiety held in his body let go. And he was able to start really taking in the experience of the music in a very nourishing way. I think he had a particular affinity for music because he has a history of being a very talented pianist. So it was just a very elegant way of how he, in that session, confronted the experience. And very much like Rachel Yehuda was saying, processed the experience. And actually, as you can hear from this example, in a very creative way. It wasn't necessarily talking about it or understanding it. He'd done a lot of that work. He'd been in much therapy, very good therapy, I would say. But this was a different way of rewiring himself, reweaving the experience, liberating himself from it, and using the creativity and his own capacity for imagination and new possibilities. I think that captures a little bit of the different ways psychotherapy gets to be influenced as well as the healing potential in the sessions themselves.
Absolutely, really approaching the experience in a different way. it sounds like is really central. So thank you so much for that example, Dr. Vaid, especially I think it's really illustrative. I'd love to sort of zoom out a little bit, if we can also just talk a little bit about what the research kind of on this has been, and what has come out of some of that research, what that research has been showing about this combination of trauma and psychedelics. I'm not sure, yeah, whoever can start, who wants to.
Rachel, please go ahead. She's doing some of the leading research in this area.
You're muted.
Thank you. The truth is, and it's really important for you to know this, there hasn't been a lot of research. There have been for PTSD and trauma, that is. There's been a lot of research on ketamine for depression. There was one study with ketamine for PTSD. I think that those studies have not used what I think Dr. Vaid is talking about, which is really ketamine-assisted psychotherapy. So what happens a lot when you just use ketamine as a pharmacologic intervention is that you find after a little while you need a little more ketamine, and then a little more ketamine, and then a little more ketamine. And really the practice standard, if you go to a ketamine clinic, will not be to introduce psychotherapy with the ketamine. That's a relatively novel thing that Dr. Vaid and others are trying to establish ketamine clinics that really do offer that full service so that your ketamine experience can be like the experiences with other psychedelics being studied like MDMA and psilocybin. I should say psilocybin or magic mushrooms. There are no trials for trauma and PTSD yet. We're going to be starting one. That's how I know. I think some people are working on it, but the excitement around psilocybin is really from studies of depression, which of course we know trauma can lead to depression, but it's not exactly the same thing as PTSD. Doesn't mean it won't work. It just means we don't know yet. But with the most information for trauma has come from kind of modern recent studies of MDMA-assisted psychotherapy that have been sponsored by MAPS, which is really spearheading. They've worked really hard for about 30 years to really develop these approaches. It's been really hard. These compounds are scheduled by the government, which means they're illegal, and it means that the DEA has designated them as harmful, potentially harmful with no therapeutic benefit. So that's been a tremendous hurdle to overcome. And let's not pretend that we haven't thought about these compounds as dangerous for a long time. I mean, most of us are aware of this is your brain on drugs. And when our family member, our dear family members, or even we get too dependent on any kind of psychoactive substance, we're also really concerned about that, as we should be. But MAPS actually did a series of about 6 small phase 2 trials. The results were really good, remarkably good. And that led the FDA to give this treatment a breakthrough therapy designation, even though the trials were kind of small. The effect sizes were large, so that added up. And what that means when the FDA designates a breakthrough therapy status to a treatment, psilocybin has it for depression, is that they're saying, first of all, the effects we're seeing here are better than the effects that are out there for other treatments. That's number one. Number two, they're saying, we're going to work with you. we're going to help you design the kind of studies that we would approve if you get good results. So there's no Monday morning quarterbacking on like the methodologies. They sit and design the study with the sponsor. So MAPS has just finished. They published one phase 3 trial, and they just finished enrolling their second phase 3 trial. So it really looks like MDMA-assisted psychotherapy will be one of the first classic psychedelics to get FDA approval. If you count ketamine, it will be the second. So it is very, very exciting. So that's the research. People like me are starting to do studies also in collaboration with drug companies like MAPS and maybe Compass Pathways, et cetera. You can't do it without really those partners in a Schedule I world. To answer other questions like scalability, how many treatment sessions do you really need? Can you do these things in group? What are the biologic mechanisms? How does it affect the brain? And so we're going to have those results in short order. But although there's a tremendous amount of excitement, really there are few studies relative to what we would hope to see to fully adopt a treatment and replace it with a standard of care.
Right. So it's still, so that breakthrough treatment designation sounds like it was a pretty major step. And also at the same time, there really hasn't been a lot of replication and yeah.
Yes, but people really see that this isn't just a new treatment, it's a new paradigm of care. It's not just introducing another compound, it's really thinking about things differently. And that's why people are so excited, because, we have new compounds, we have new psychotherapies, but that hasn't changed a lot. This is really just looking at things very, very differently. And somebody asked what MAPS is. It stands for Multidisciplinary Association for Psychedelic Studies. It's actually a pharmaceutical company that is going to turn over all of its profits to a public benefit corporation. They're very committed to really bringing this treatment to the many, many people that need it, and trying to do this in a cost-effective way that will not leave out the people that perhaps will have a hard time paying for it and stuff like that. So they're a really wonderful group of people, and I hope that their data from their recently completed trial are as good, the second trial are as good as the first trial, because then we can get very, very excited about having something to offer someone who has maybe not done so well with prior approaches that might make a difference in their lives.
Absolutely. Absolutely. Thank you for laying that out so quickly. Dr. Vaid, did you want to add anything to that regarding the research?
Add a few things. One thing that I think also we're all very excited about with the treatment for trauma, and I think this new approach, which really approaches whole person health, not just symptoms and management of symptoms, which typically in psychiatry we're very good at diagnosing and have a whole range of medications to try and suppress symptoms, which sometimes can suppress even the range of feelings and make people numb or have a lot of side effects. What we're excited about with these medicines is treating the whole person, but also the trauma that we have all to some extent experienced, obviously with different severities, that make us more fragile or more susceptible. These are kind of traumas of omissions. Sometimes people have had not only something bad, a bad event that happened to them, but maybe have had poor care early on. They did a lot of neglect, a lot of deprivation, early deprivation and neglect. Even if it wasn't actively something being done to you, it's something that actually wasn't done, that should have been done, that causes enrichment or the cultivation of identity and self, and creates a susceptibility towards mental illness or mental suffering later on in life, or if there are traumatic events. Less resilience and less coping strategies, less flexibility in one's character. And you can see if one has to rely on rigidity and less flexibility, there's less health and less ability to tolerate trauma and difficult situations. So what's nice about this approach is, aside from being able to metabolize real events and trauma, like the case I mentioned, from events that happened that were distressing, there is also a real incredibly exciting benefit of building wellness, of building health, building resilience, corrective experience. And that's part of the psychotherapy, having the care that one hasn't received and really being able to absorb it and heal, and as well as bringing capacities and new coping skills, new flexibilities in one's repertoire of coping strategies and ways of recovering and enriching one's personality. So I think that's a very important thing to add when we're talking about trauma. There are these hidden underlying traumas. And the other thing I wanted to add, as Dr. Yehuda is saying, there's so much exciting in the field and in the popular culture about psychedelics, but it's unfortunate the only medicine that is really available in a legal way, not in a research capacity, is ketamine, which, some people even wonder, is it a psychedelic? Because it doesn't work on the serotonin receptors, which is how classical psychedelics work. It's a different mechanism of action. But in the sense of it being mind manifesting, some of us classify it as a psychedelic, although technically it doesn't fall into that category. That is the only medicine that is available. And it's now burgeoning in interest because there have been so many good studies showing it to work very efficaciously as a novel antidepressant. But that's really how it's being dispensed, which is quite different than using it in this new way as a psychedelic catalyst for psychotherapy. So it's important for people to know the limitations of these medicines. And even though there's tremendous excitement, there's not much accessibility at all right now at the current time.
Yeah, that does seem to be the theme, that there's still a lack of access, and there's still things are still moving relatively slowly. Dr. Yehuda, you sort of used the phrase or gestured at the idea of this paradigm shift, right? That this just works in a different way than kind of some of these other compounds that we use as psychotropic medications. And someone had asked in the chat, what happens during a session where, for example, ketamine is given, or in the study that you mentioned, for MDMA and trauma, MDMA-assisted therapy. Can either of you speak to kind of that really nitty-gritty, like what happens during a session, and how is this kind of different from other kinds of psychotherapy and other kinds of medication?
I think we could both speak to it. Would you like to start, Rachel?
You're muted.
Yeah, and you could pick up what I miss, first of all, it's very important that there are many sessions to prepare for a session with a psychedelic. You don't just go in there, hi, how do you do? Let's have a psychedelic. You have to really build trust with someone. When you take a psychedelic in someone's presence, you're very vulnerable. You have to really develop some sort of working relationship. You have to talk about things like, well, what happens if what will you do? Do you like to be touched on the shoulder, or don't you like to be touched? If you kind of if you start reliving a traumatic memory, you have to kind of go through the different scenarios of what kind of interventions might happen, what will it be like. You come in on the morning of a dosing session at about 9 o'clock. We did one today. You're given a dose of MDMA. You're in a very non-clinical environment. Our MDMA room is gorgeous. It has really incredibly beautiful furniture and artwork and carpeting, and it's very cozy, and great lighting and a lot of daylight. There's a stereo system there. You put on headphones. You put on eye shades if you want to. There are fresh flowers. There are things from nature. So this isn't your typical clinic. You can recline on a bed if you want to, or on a couch. We have both. And the therapists have 2 big chairs on either side. And they're with you the entire time for 8 hours during the duration of a session. About an hour, 45 minutes after you take the first dose, you're asked if you want a little more. You start to feel good in the beginning. It's called ecstasy for a reason. Your body starts to feel kind of good. And then the therapists will let you either go into yourself with the eye shades and music. Maybe they'll check in on you, how you doing in there? And at that point, you may take off your eye shades and your earphones, and you may want to talk about where you are and what you're experiencing. And you will probably at some point revisit not only a traumatic memory, but a lot of things from your past. You'll start to make connections and associations that weren't there. You'll have a very wide range of feeling. You'll feel a real deep connection with the people that are in the room. It's kind of a sacred experience in some way, a very intimate, profound, revelatory experience. And then you're not hungry because MDMA, it's an amphetamine essentially, but at some point after 6 or 7 hours, the therapist they'll keep asking, do you want to eat something? At some point you will. And at the end of the session, you'll be sober, you'll order your dinner. In our studies, you'll stay over in that very room with an attendant who's going to check on you. And the next morning, you'll begin the first of 3 integration sessions before you have another dose. So each session is really is bracketed by a lot of preparation, a lot of integration. And really, I think you can talk about what happens in a medication session for a long time afterwards. People will start to feel very different after the first session, but how long it takes to completely heal is going to really be a very personal thing. And it also depends on what kind of environment you're being returned to. A lot of people that have taken psychedelics, some of them have been on the privileged side and they're being returned to really great environments. And, if you have to go back to kind of a difficult marriage or a difficult home, you might need very different kind of support. But it's always good in the preparation to identify who your person is, and sometimes we meet them, and sometimes they're really a big part of what happens, and because they're going to be needed for the support afterwards. So that's kind of what happens. I'm sure I missed a lot, Gita, if you want to pick it up.
I think you captured the elements beautifully and how unique the process is. And I would say each medicine that we're talking about, MDMA, psilocybin, which is magic mushrooms, or ketamine, all have different flavors to them. The process itself, that Dr. Yehudin mentioned, is quite similar. There's different lengths of time based on the different medicines and a different experience. It's very much, I like to use the analogy of you can learn about yourself through traveling through different countries, and each country, if you were to go to Italy, you're going to learn through a very different atmosphere than if you were to learn about yourself through traveling through India. So I like to use that metaphor because it gives you a sense of how different each medicine is, but they're all different paths towards learning about yourself through the experience itself. I would say that the pieces that I would emphasize are that there is so much healing that can happen from being in a non-ordinary state. And we know already from meditation or even from breathwork practices, and different cultures have different traditions, because they've long known that if you kind of drop into different meditative states, there's a lot of healing that can happen in the mind or in the body. But that's very difficult, takes a lot of discipline, takes a lot of practice. And actually people who are more susceptible to mental suffering, it's hard to get someone to be disciplined to work on it when their mind is overactive or full of ruminations. And in some ways, these medicines are a shortcut that take us beyond the thinking mind to tap into some of this knowledge of healing that is in the body, and from a different place to release and metabolize the trauma or the experiences, or to think about things differently and to have access to different ways of understanding their past. To color that in a little bit, I'll give you an example of one lady I worked with, who I've worked with for a long time. In a session, she was able to recognize this narrative she had, which was true, of her mother being a very impaired mother who struggled with depression her whole life, culminating in her suiciding as a young woman. The patient was a young woman when her mother suicided. Really had been such a terrible experience growing up for her. But in the session with ketamine, she was able to remember her mother as vibrant and fun-loving and really sensual and a dancer and a wonderful charismatic character, which was an aspect of herself that she had lost through the traumatic memories of growing up with a very depressed, suicidal, unstable mother. She had actually lost access to this other part of her mother that was full of health and vibrancy. And it was very beautiful for her to have a connection with a different aspect of a good mother that had really been blotted out. And through that pathway, actually find her own good values in herself and finding herself through that as being a sensual, attractive woman and being someone who was very lovable in the most elegant way. It was really revealed as I was watching her remember her good mother, how much dampening those memories, not even volitionally, or even the overshadowing of them from these negative images of a depressed mother, had actually shut down her own similar feelings about herself. So there was tremendous repair that came from the process itself. There's also a real corrective experience, as Dr. Yehuda is mentioning, the preparation and the real relationship of trust and safety. For some people, it's the first time they've ever had that level of care and attunement and real attention and really respecting the autonomy and the sovereignty of their self and their being. So that's a very important element too. But I think the essence that I value so much is this intelligence of the body and the mind to heal itself. Now, when I mention this example, I hope it captures the creativity of this young woman or the participant in their being very active in being able to guide their own healing, to listen to themselves. And it's very much in a process directed instead of it being imposed on the subject. It's very much like following dream work almost, except for it's a lucid dream. And it's one where the therapist is engaged with the subject.
Yeah, that sounds like thank you both for describing that in so much detail. I think it really conveys how the experience can be really powerful. I'm going to take a moment because we have our Spanish interpretation up, and I want to speak to any Spanish speakers that may not have seen that option. Para hispanohablantes, por favor, hacen clic en el globo en la parte inferior de la pantalla y selecciona español para oír la interpretación en vivo en español. Y si necesitan ayuda, por favor, piden ayuda en el chat y yo puedo intentar ayudarles. Gracias y lo siento muchísimo por el demoro. So thank you both. I am wondering if you can speak a little bit, Dr. Yehuda, you'd also, and you both sort of spoken to this as a delicate place that there's a lot of vulnerability, it sounds like, involved. And so I'm wondering if you can speak a little bit to the potential risks of this as a treatment and things to be aware of, particularly if folks in this presentation may be interested in pursuing this as a form of treatment for themselves or for their loved ones.
There are a lot of risks. This is not a legally approved treatment yet. Ketamine is. There are probably risks of ketamine too. I'll let Dr. Vaid tell them because she will know them more than me. But everybody can't wait till the FDA approves these things. So one risk is to put your hands into someone who is not well enough trained to deal with your trauma. Many people may have kind of above ground or underground training in how to hold presence or be a container during a psychedelic journey. But facilitating a psychedelic journey for somebody with mental health problems and serious developmental traumas and post-traumatic stress disorder also requires training in trauma and PTSD and mental health. It just does. And there's just no way to say that clearly enough. that is a potential risk. Now, sometimes people work together with their therapist and a psychedelic therapist. I think if you can arrange something like that, where you really have this team of the person that is very supportive of your psychedelic work, though the person doing the psychedelic work isn't really a trauma specialist, maybe they can work together. I think in the future that might be ideal. In the, when you, this issue that you're very vulnerable is a very important issue. I mean, a drug that also increases interpersonal trusts with your therapist cuts both ways. Your therapists have to be worthy of that trust. And again, that's part of the training. You want people to have licenses. You want them to be to adhere to a high ethical standard. What you're not hearing me say is that I think these drugs are dangerous, because that's, I don't think, one of the risks. I think that you can have some, there's a side effect profile. Your jaw can clench. Your blood pressure will increase. You can feel nauseous. There are some physiologic symptoms that people can experience, but I don't think that the compound per se is dangerous, and I also don't think it is physiologically addictive. It might be more psychologically addictive than we're thinking, because many people that have had a psychedelic assisted psychotherapy, a lot of them want to do it more than once, even though ostensibly your symptoms should be reduced quite a bit. So that's something that still needs to be looked into. But I think in terms of the compounds that we have in psychiatry, this is on the safer end. Also, the fact is you don't keep taking the medicine. That's a huge benefit here. So again, I worry the most about people who think, oh, I can just get mushrooms, I'll just turn on some music, I'll take it off my phone, and I'll get some eye shades, and I'll just maybe have a friend on call. And what could happen? Well, what could happen is that you start to go into some really dark places, and you don't know how to modulate the fact that you don't have as much control over your own body. And you might not even be able to do simple things like go to the bathroom on your own in a safe way. So I worry very, very much about people deciding that the therapy part isn't so important, and it's really all the powers in the medicine as long as I get the drug. And of course, it goes without saying that you want a tested compound, but increasingly, I think people have been able to get tested compounds. It's not just that; it's the whole preparation, setting, environment. And I think that there are risks associated with trying to get this treatment before it is FDA approved. I know that that won't stop a lot of people. If you are saying to yourself, but I'm so desperate, this is my last thing that I can do, I would probably not advise you to do this, because you're putting just too much into something that we're still in an early phase of. A lot of people contact me, I'm so desperate, I've tried everything. I need to get into your trial. And I write back and I say, well, what you need is someone to talk to now, somebody that will help you now. And yes, trauma treat work is really hard. People have such complex problems sometimes. They can overwhelm any specific therapist or a specific system, and it is a problem in our society that we don't have as good access to regular mental health as we need, and that does increase people's desperation. But I'm not sure that I would give this to someone who was that desperate, but I'm really interested, Dr. Vaid, in whether you agree with that.
Well, I do agree with that, actually. I feel like for me, when I work with someone, and I see people all the time who are desperate, I try and stabilize them first. Because really, if you're that desperate, it's a very different process. And, for stabilizing, ketamine can be helpful sometimes to manage symptoms, but that's applying it in that same way as an IV to treat symptoms. So some of the psychedelics can be very good if they're used like novel antidepressants or anti-anxiety agents, but that's a different thing. But really, to have these medicines work well, you do want to have the person be in a more stable state. So it's sort of like psychotherapy. If someone's drowning, you can't do meaningful psychotherapy because the goal gets to really help the person calm down, manage themselves, have some coping skills, maybe even think about, would medication be a resource? If you're drowning and you're unable to keep your head above water, you can't start tapping into the deeper issues because you just want to make sure you have your head above water. So the same kind of rules apply. And I think Dr. Yehuda's right. These medicines from a pharmacological point of view are actually fairly safe. That being told, there are some concerns you have to worry about, and it doesn't matter if they're relatively safe. Just with antidepressants, I prescribe them all the time, and sometimes I can give someone Prozac and it makes them manic, and they would never become manic if they didn't get medication prescribed to them. And these medications also can have adverse events. So in and of itself, they're safe, but they really need to be supervised by someone who could manage if you're the 1 in 500 who has a horrible side effect, or if you're the person where your blood pressure shoots up, which generally in and of itself is not a big deal unless your blood pressure is on the high side anyway, in which case a doctor should be monitoring that and saying, we're not going to give this to you until we get your medication stabilized. The reason I mention of this is all common practice when you're prescribing a medicine, but in the underground, it may not be. And that could be not because these aren't great facilitators, but they don't have that kind of perspective in treating someone. And second of all, you don't know really the skill set, and there's so much trust that you're bestowing on the therapist. You really have to know who you're dealing with. And I agree with Dr. Yehuda, it's very dangerous because these are powerful substances. And aside from pharmacological effects, you are so vulnerable and in such an altered state that someone could inadvertently, even they're trying to help you just through lack of knowledge, traumatize you. I have had people work with therapists who are trying to do their best and not even trying to do something harmful, but if they leave the room or leave the patient for a little bit during a non-ordinary state, that can be a very amplified experience in the context. It can really bring up in real ways abandonment issues and neglect. And so you have to be meticulous in the care in the session. And the other thing that really is important, is becoming a big issue, is boundary violation, because someone is altered and so vulnerable. In therapy, we know there's a term we use a lot about transference. It's not uncommon, and you see this in movies portrayed, that when one goes into therapist, it's fairly common that you can have very strong feelings towards the therapist. We call that the transference. And actually in the treatment, we use that to actually galvanize the treatment and learn about the person's early life. So falling in love with your therapist can actually give you a sense about the early object relationships and be a vehicle towards change. But you have to make sure the therapist doesn't take advantage of it by then, crossing any boundaries or violating, because it's not really about the therapist, it's about the person's past life, their emotional life, and how the forces are really very much geared towards having that all come up. And I would say in psychedelics, it comes up even more so. It's really dramatic, which is once again an even greater opportunity to work through those and to have healing. But if someone is taking advantage of the person or doesn't even know how to manage that, you can get into a lot of hot water. So I would say there's very much a lot of concern, particularly people, when we're all desperate, we take chances, and it's the worst time to be taking because there's less wiggle room. So I would definitely say you have to be careful. The other thing I will mention about risks is ketamine, we do know, can be addictive. It can be habit forming. So that is a medicine which is not only, sometimes people get addicted to the experiences I see, but it's more that you can develop a dependency, which means that you could really stop having the medicine working until you need more and more of it. And then you can start actually craving it. So that is something has to be administered very, very cautiously, which is really why it has to be really taken into consideration how many treatments and how is the person responding instead of self-medicating. And you can get into a lot of trouble with addiction.
Yeah, absolutely. Thank you both again for going over those reasons to be cautious. I think that's really useful for folks to hear. I do want to. I know we've had quite a number of questions in the chat, and I do want to shift over to answering some of the audience questions that we've received. But before I do that, I would love to just, if we could end the discussion portion of the event, just if I would love to hear from both of you, what an overall vision of person-centered system, of a person-centered system of healing practices for people dealing with trauma, dealing with depression, dealing with some of these issues, what that could look like. And then we'll move into questions from the audience.
Rachel, please go ahead.
Okay, thanks for that question. We're very focused on reducing people's symptoms and talking about the trauma, and we're a lot less focused on kind of reintegration into society, helping people experience pleasure, be motivated to live really good, full lives, kind of reconnect and establish relationships, take good care of their health. Trauma survivors do not take good care of their health in terms of eating and exercising. Very often it's just no on the list because they're so preoccupied with so many other things. So the whole person model is really about a lot of stuff that needs to be in place in someone's life after they leave the therapy. And that's what we do hope that they will do, leave the therapy. What will their social system looks like? Who will they go to for support? What will they do with their time? How will they live really good lives? How will they reconnect with their loved ones? So that's what it means to me.
Absolutely. Thank you.
And I would really just add, maybe it's the same point really, that what I'm really excited about with psychedelic medicines, but I think it allows for us to think also about the systems to support them, is they do cause increased empathy for the self as well as other people, so the quality of relationships towards self and others gets to be really enhanced. And it helps with community building. And we all know that loneliness is a big indicator of making someone more prone towards depression. So community becomes very important. And what's interesting, it improves nature relatedness. A lot of these compounds have been shown to have much more sensitivity to the healing potential of nature and more concern for what we're doing to our nature. So it would be really nice and hopeful if a lot of these pieces could be added to mental health as one becomes more available to take them in. And I think it offers a whole different shift from the symptom management to whole person, but also community and ecological health.
Beautiful. Yeah, I think we could all benefit from a world where that was more integrated into mental health treatment, all of those things. So I do want to go into some of the questions that we've gotten from the audience. We've gotten a number of really great questions. One I would love to start with is there any, there was a question about sustaining power. Has there been any research on how long some of these effects last with some of these trials? And has there been any, have there been any findings regarding the longevity of some of these effects? Dr. Yehuda, you're nodding. I see you.
I mean, look, that's the big question. I mean, what we're thinking right now is that a year and a half later, people still seem to not only be as good, but a little better even, that experience kind of was a pivot. But I want to say something really important about all findings, even the fantastic findings of Mdma, which assisted psychotherapy and PTSD, which really have been robust. The psilocybin have been less robust. And the ketamine have also been less robust, but good. And that is that even in that study, a third of the people still have PTSD and may not improve that much. So we're talking about the fact that about 2/3 really don't have PTSD anymore after the treatment ends, which is shocking because the way we think about mental health right now and the way we teach it in medical schools and psychology programs is, well, it's like diabetes. You just have to manage it your whole life. And this is really, I mean, why it's a shift, a paradigm shift, a new paradigm of care, is that it's demonstrating that at least for some, and maybe even the majority, you can get over a hump. You can cross over to the other side. You can leave the PTSD behind. I am not sure if that is the case with chronic depression. I am not sure if that is the case with kind of chronic anxiety disorders. I don't know. But this idea, but we've all known that with trauma, it is possible to cross over the other side. It's just that not that too many people do it. We've seen it. We know it's possible. But this increases those numbers significantly, but it's not a panacea. There are still people that really don't respond. And that's why the research is so important, because we have to be able to identify people before we give them these medicines who will be responders and non-responders. And there are ways that we can do that.
And I would just add that with ketamine-assisted psychotherapy, which, you know, as we're pointing out, is different than ketamine used intravenously as an antidepressant, I would say anecdotally, we're getting a lot of good results in terms of treatment, as well as wellness building and symptom reduction and overall well-being. But we do need really research to support it, because it's very exciting to see these findings and getting great results, even hosts of results. But that's not really enough. We do need to back it up by real research being done in academic institutions to verify and really go further into delineating what all the variables are, so we can improve our treatments and just get much better new range of treatments and tools that really work.
Yeah, the information is so important. There was a question about the just sort of the ideal patient, and I don't know if that's something that we know yet, because there's sort of been a emphasis on the fact that there's a lot that we don't know. But is there anything that we know, sort of, Dr. Yehuda, you mentioned, you know, responders and non-responders. Is there anything that we do know about folks that may be more, that may benefit more from this kind of treatment?
I don't think we do, actually. I think one of the things we do know that has been really promising is you can be pretty symptomatic, and you could have years and years and years of even early developmental traumas, and you can be a dissociator, and this treatment might still work for you. One of the really interesting findings from the phase 3 trial was that it seemed like there were even better outcomes if you had really serious PTSD symptoms. So it's not a treatment that you know, discriminates against very serious cases. That's good. But no, we don't know really who those people are that didn't respond. And we also don't know if it's a medication effect or if it's the impact of the psychotherapy. So we don't know things like that. And those are very important things to learn, because maybe the critical factor is the kind of psychotherapy that is received. So we are going to, we're going to have to keep an eye out on those things.
I'd love, Dr. Vaid, did you want to, yeah. There's been a lot of questions about accessibility, and as you both addressed, that is a huge issue with these sorts of treatments. I would love to talk a little bit about that. There was a specific question that said, you know, my understanding is that treatments are very expensive, and if you could particularly speak to any opportunities for folks that are struggling to afford treatment. So I guess, and I know that's going to be very different for ketamine versus some of these other psychedelics, but if we could speak a little bit to both, I think folks would find that really helpful. Although I understand that the answer may be there's not a lot accessible, unfortunately.
Fortunately, there isn't really, certainly with ketamine that's available, because, you know, it's not covered so easily. The only way ketamine is generally covered by insurance is if one is eligible for treatment-resistant depression with Spravato. And that has a very strict protocol where you have to have failed a number of antidepressants and be taking an antidepressant presently and have an administration in the doctor's office, which is a very different protocol gearing at the pharmacological effects and not so much the psychedelic experience. So that's quite different than what we're talking about today with psychedelic-assisted psychotherapy. But that, the good news about it, can be reimbursed and covered by insurance. In terms of insurance coverage, it's quite tricky because these sessions, as you can see, are quite long. The sessions in my office are 3 hours long. And generally insurance tends not to cover that, which is very unfortunate because a lot of the people who really need these treatments don't have insurance. I would say, you know, there are sliding scales in clinics. And so there's, you know, something to look into. There are some organizations that do offer access to care. I certainly would say at the Ketamine Training Center where I teach, we do have our trainees participate in an access to care program. So everyone who's trained, we hopefully have them join our group, and under that umbrella, agree to reduce our fees, like cutting them in a half or sometimes a quarter and having them subsidized by a not-for-profit organization. So there are different facilities, and I think SAGE in California are trying to offer treatment. So there's an effort, but there needs to be more.
Whoops, sorry, Dr. Yehuda, I muted you. Thank you for putting the contact number in the chat.
Yeah, I just want to say in our center, treatment is going to be free, but it's not treatment, it's research. And there's a very important and gigantic difference between going to see somebody for clinical treatment and participating in a clinical trial. If you go to see somebody privately, they'll work with you and they will optimize the treatment for you. When you participate in a clinical trial, you have to meet certain inclusion-exclusion criteria to be in the protocol, and the protocol is the protocol. And I think some of the problems that have occurred in some of these trials is that the patient needed more and the protocol was over. And so, that's something that in clinical practice can be solved for, and in a research setting is really hard. Right now, we only have one trial that's actually rolling along, and that is Mdma for combat veterans with PTSD. So you can't be in that study if you're not a combat veteran with PTSD. We're going to start a psilocybin study for PTSD within, I would say, the next month and a half or 2 months. So take the number, but if you call it now, you can't get in. If you call it in like June, we can screen you. We are going to develop other protocols. It takes time. It's not a legal drug. There's a lot of paperwork. There's a lot of hoops to jump through. But we're not the only people that have trials. And so your best bet now, if you don't want ketamine and you want to try Mdma-assisted psychotherapy or psilocybin-assisted therapy or even LSD, I think there are some trials going on with that for PTSD. Your really best solution is to find a place that is doing clinical trials. NYU is doing clinical trials. They have a center, and there are centers popping up all around the country in academic medical centers. You can also contact the organizations and drug companies that sponsor these medicines, that are promoting these medicines and bringing them to the FDA for a trial near you they might not know.
Thank you both. This is an interesting question. Is in programs to train professionals to work with psychedelics, is it a requirement that they experience the drug themselves? And if not, do you think that it should be? I think that's a very interesting question.
I'm sorry. I was so distracted by this comment. The most accessible way is to get MDMA yourself and follow the FDA trial protocol. And I want to make sure that this person knows that that's not our recommendation. That I don't think Dr. Vaid or I think that that is true. So that might be somebody's experience, but it's not the professional recommendation. Just want to really make that clear. So if you want me to answer, you'll have to ask your question again. I'm terribly sorry.
No, that's fine. I appreciate that addressing that point.
I'm happy to jump in because
yes,
training programs, and there are a lot of training programs popping up right now, and some of them are online and some of them are experiential. Once again, you have to do your research of what is the quality of the training, what is the outcome, how much you're going to learn, and what are you really looking to learn. So I think you have to be really careful. There are trainings which are just a day long, a few hours long, weeks long, a year long, and obviously the quality is going to be very different. Some of them are very didactic, some of them do involve in person. In terms of, is the experience important or necessary? I think you're going to see a variety of experiences and a different of opinions. There probably is not a right or wrong answer. My own personal opinion is, I think it depends on how you are really working with the medicine. If you are working to administer these medicines as an antidepressant, I think that's a different skill set, very much to administer a medicine and make sure the person is safe and you're watching over them and looking for side effects and knowing how to manage side effects. That's a very different scope of practice and skill set that's required compared to administering psychotherapy and psychedelic psychotherapy, which is very different from conventional psychotherapy. And as Dr. Yehuda said, if you're doing psychedelic psychotherapy with high-risk populations such as PTSD, that's a different skill set and a different scope of practice that you need to have a lot of knowledge about working with PTSD and traumatized individuals, as well as knowledge about psychedelic psychotherapy and how it presents itself and how it needs to be navigated within that population. I would say the training program I'm involved with, which is the Ketamine Training Center with Dr. Phil Wolfson, involves training for ketamine-assisted psychotherapy. It is an experiential program. It's about psychotherapy, which is what I'm the most interested in, the most expert in. And for that kind of practice that I am espousing, I really feel it's important to have knowledge and direct experience to understand the experience yourself for that application. So for that, the program is very experiential. And if you're trying to work in that modality, I think it's really an important component, very analogous to my training as a psychoanalyst. You can't do psychoanalysis, the process, or even understand it if you haven't experienced it yourself. And I feel there's a tremendous parallel in that realm of psychedelic psychotherapy to understand the landscape and understand the experience. It's such a unique experience and process. I think to understand it, to go through it yourself, can be really incredibly invaluable.
Yeah, I agree with everything Gita said. We, as part of our center, we are offering training for free for MDMA-assisted psychotherapy to therapists that are already licensed or going towards their license and have expertise in PTSD already, or now you can be a resident or an intern. But yeah, so we think it's easier and is very different to teach people who already have a background in trauma therapy how to work with psychedelics. But that's going to be a very specific program, and we're offering it to people who work with veterans in the VA and the DoD, and also people who work in community-based care, because a lot of these training programs are really very expensive. I paid a lot of money to be trained, and the cost is prohibitive. If you are going to one day turn around and use the information in a private practice, then I get it. But for for many people, hopefully there will be an opportunity to, I hope there's a future in which these treatments will be available in community settings. And I think we have an obligation to make sure that people understand how to work with these medicines. And even if they don't, they're going to have patients that did try it on their own, and they're going to come in afterwards. I guess de facto integration. And so we do really need to communicate with our colleagues and really teach them about psychedelics so that it's not a foreign thing, even if you yourself never end up administering a psychedelic as a provider.
Yeah, that all makes a lot of sense. Dr. Yehuda, could you specify, does the Center for Psychedelic Psychotherapy and Trauma Research, does that also provide training? There were a couple of folks in the chat asking for clarification, if that's where.
Yes, we are, we're funded to do about 2 or 3 a year, but there's such a demand that I think we're going to try to squeeze in a few more, and we're going to try to get those funded. But yes, our training director is Dr. Miriam Spurka, Sperka, and by calling that number and asking for her, she's definitely keeping a list, but don't expect it to be like next week. It takes a while to get these things going. We are transitioning from Zoom to in-person trainings also, but we'll probably have Zoom trainings as well as in-person trainings. And again, we're a center for a year, so give us time to scale up, but it is absolutely our mission to do this and offer it free of charge. Again, I think that part's really important. But again, there's going to be preferential admission to people working in serving people in the community.
So that's Dr. Spirka, Spirka, for training.
Spirka.
Perfect. Okay. Just putting that in the chat as well, because there were folks were, I think, definitely interested in training, and we would love to, as you've both specified, we want folks to, as much as possible, to get access to some of these opportunities. There have been a couple of questions about complex PTSD versus PTSD, and I'm wondering if both in terms of what are the differences, and then what does some of what you have both been speaking about in terms of PTSD also apply to complex PTSD? And I'm wondering if you can speak a little bit to that.
Dr. Vaid, do you want to start out with that?
Actually, if you would mind going ahead, I'm just having a problem with my battery.
Oh, yeah, mine's running low too. And it is also the end of the day, so all my batteries are. So PTSD, everyone understands. It was initially meant to describe long-term consequences, mostly of a single episode trauma, mostly in adulthood. Obviously, you could also have PTSD from a circumscribed childhood trauma, like being in an accident or being kidnapped or some terrible thing like that. Many immediately felt that this diagnosis was very limiting and did not capture really the average person that comes into clinical care, which usually has a lot of developmental traumas. Traumas started from an early age. There were a lot of them, and sometimes, the assumption we make in regular PTSD is that you have a great home environment that will support you through this terrible event that happened externally. Well, in developmental trauma, sometimes your own home is the problem and there's nowhere else to go. And so and there's no before trauma, because if it starts early, you don't even know what you're trying to return yourself to or something like that. So pretty soon, people realized that the symptoms of PTSD were just not enough, inadequate to describe really the full spectrum of personality changes. You just look at the world so differently if you're constantly feeling a threat when you're young, and you don't really know who you can trust, and the people that you naturally would trust are not trustworthy. So that's complex PTSD, can lead to a lot of outcomes. Would these medicines help? I don't see why not. It has to be tested. The current trials allowed you to have complex PTSD, but you also had to have regular PTSD. So there had to have been like a focal trauma because your PTSD scores couldn't be scored otherwise. So it is a study that we are planning to look at people that with disordered personality, probably a lot of trauma, probably a lot of early trauma, but not. So we're going to look at that. Sitting here today, my guess is that I think it'll be effective, but I wonder about having maybe a longer integration or something like that. So again, we won't know until we look, but conceptually, I don't really see why people with complex PTSD would be barred from these kinds of approaches. What do you think, Dr. Vaid?
Well, I love that you emphasize the lack of safety, because I would say what I found in working with these medicines as tools is that safety is so important, because so much anxiety that's held in the mind and in the emotional life of an individual and in the body, and sometimes even in the nervous system, because the person has never felt safe from birth because the environment was so unstable, that and all of that gets encoded in our being. The permission, the provision of safety in these sessions in a way that it can be actually absorbed experientially, almost like going to the gym. I feel like sometimes it's like developing, just like you go to the gym to build a muscle, even if you haven't ever worked it out, you have the potential, this inherent potential. You can really see individuals who have really significant anxieties and fears that are now part of the personality, or catastrophic, extreme ways of coping with early existential fear. You see the person over time recovering and cultivating safety in all of these different domains: mind, body, emotional life, nervous system. And to me, that is, I think, really one of the features that is so different. And what you see is when all of that energy that is put towards surviving and coping gets to be released, it's a very beautiful thing, because it gets actually shifted into imagination and play. And we know in psychotherapy and psychology that play in children is very important, but actually play in adults is very important, because it's through play we can actually reimagine ourselves, refine ourselves, develop ourselves. So it's a very elegant process. And I think it loops back into your question about complex PTSD. There's also some of the difficulties with diagnosis. We do need diagnosis for research and for treatments and for understandings, but it's very reductionistic compared to the complexity of human beings.
Yeah, absolutely. And I see some folks in the chat kind of talking about the difficulty of having overlapping diagnoses and kind of the sort of discussion of whether certain personality diagnoses are related to trauma. So let's see, I think I've been looking back through the questions, and I know we're almost we're wrapping up at 5:30 Eastern. So I'm just trying to see if there's any last question that that we can. I think what I'd like to wrap up with, since we've just got 3 minutes left. And I think we've kind of addressed most of the general topics that the questions spoke to. And I apologize if we didn't get to your specific question to folks in the audience. We wish we had more time, but we always are trying to get as much information into as little time as possible. So I would just love to end with any closing words, closing thoughts that you both have for folks that may be interested in these forms of treatment, either for themselves or for their family members. what would you like for our audience to take away today from what you've talked about?
Well, I'd like to sort of really emphasize that this is really a paradigm shift in healing. It's a very exciting field and an emerging field and discipline. And there is a lot to be excited about and a lot to learn and a lot more that needs to be discovered. And if you are interested and are looking for paths towards treatment, be really careful and do your research and really be very thorough. Do not be impulsive. There is no quick fix. It is a process, but really to be very careful because there are a lot of dangers one can get into too.
Ask your doctors about psychedelic medicine so that they will understand the need to educate themselves about this. If you're politically active, talk to your congressman about psychedelics, your healthcare system about psychedelics. It is very, very important that you take an advocacy role so that we can train people and really bring this to the public. I agree with Dr. Vaid. We want to be careful. We don't want to be premature, but we definitely want to get there because there is a there to get to. Thanks so much, everybody. It was such a wonderful experience.
Yes, thank you so much. Thank you to our audience members. Thank you to our interpreters for helping us attempt to make these events more accessible. And I know there were some comments just regarding the importance of holistic care and of addressing some of the societal issues that cause trauma, that cause some of these things to be so inaccessible. So we definitely want to encourage everyone to take that view. And yeah, thank you so much to our speakers, Dr. Yehuda and Dr. Vaid. And thank you all so much for being here.
Bye.